concluded the whole conference in a single talk. We move on to a special lecture, that is Dr. V.K. Agarwal oration. I would request the chairperson to come on the dais so we can start the session. And I would also request Dr. A.P. Singh sir to remember Dr. V.K. Agarwal sir.
Sharma is not a guru, he is a Mahaguru. And at our times when we are getting taught in the institute, so we have Brahma, Vishnu and Mahesh. Two of them are present at this time. Professor Amit Gupta is also and Professor Sharma is also. One Dr. Kher is missing. And so these three are called as Brahma, Vishnu and Mahesh. First introduction from my side. Otherwise, he is a well-known figure internationally in transplant immunology, in transplant physiology, and in the nephrology. He has been director for 2 terms in the SGPGI, Lucknow, and head of department for acute nephrology. He is a president and past president of various societies, so much to count them. Main is he is a nephrologist and a very good teacher, teachers of teachers, and also, as he was saying, about Srimad Bhagavat, so we are now going towards some gyan from the Professor Rajkumar Sharma sir. Please.
Thank you, Arvind, for this kind introduction. The orations are occasions to remember people who have contributed immensely through their dedication and commitment, and that's what we heard about Dr. Agarwal. So I am honored to be standing here and talking to you. And I know he was a great pediatrician, and it's the pediatric care which is the backbone of any, or an index of health delivery in any system. So I'm going to touch a topic which is very relevant today, the cardio-renal metabolic syndrome. It's a long term, and I'm telling you, next year, this term would become longer. It will become cardio-renal metabolic hepatic syndrome. Because these definitions are actually highlighted because we as physicians have to understand that what is available to us to act, intervene, and take care of chronic diseases. Chronic diseases which are linked to lifestyle have replaced the epidemics of infections. Now nobody talks of malaria, even tuberculosis. We are talking, they actually claimed that within a year India would be tuberculosis free. So that is the time which has come. Even filaria. Nobody could think that filaria would be eradicated. And now we hear on the radio, on TV, messages by the government, what all they are doing. But these are the diseases which have come to the forefront. The epidemic of chronic lifestyle diseases. This is the perilous paradox of our times, which we have to remember as doctors. Some of the greatest human and economic burden is caused by one of the most treatable yet underdiagnosed condition. And chronic kidney disease is one of them. Diabetes, cardiac disease, cancer, metabolic diseases, they also form this list of epidemic of chronic diseases, which we as doctors have to understand and intervene. Our current practice in this area is we diagnose these diseases too late. We are too conservative. We feel nothing can be done. These are lifestyle diseases. The individual is responsible to come to that stage, and we feel that our options for intervention are limited, but it is not so. This is what I'm going to present. And our interventions are really targeting very few people. If you have cardiac disease, we have so many interventions. But the number of patients who benefit by cardiac interventions are too few. So let us be more pragmatic and understand how we can intervene in cardio-renal metabolic axis. The first issue is that awareness of this is very low. 1 in 5 persons with diabetes, even in USA, where people are more aware, they don't know that they have it. And 9 out of 10 people with chronic kidney disease do not know that they have it. And in India, 10% of the population has chronic kidney disease. The other thing which we have to understand, both in the West and also in the developing and underdeveloped countries, the underprivileged people, the minorities, the older people, the elderly, are very heavily, disproportionately affected by these diseases. These are inequalities which we need to address. Even Western countries, they are really trying to intervene, keeping in mind that the health care should be an equalizer and not a discriminatory health delivery systems in terms of screening, diagnosis, and access to the management. The lack of symptoms for chronic kidney disease is one of the major problems for early diagnosis. The patient has even the tests are normal. You will find that till the creatinine or the GFR is less than 50%, the serum creatinine may appear within the normal range. But if you put that creatinine in your equation and the formula to get the eGFR, you will be surprised that the eGFR is 48, while it should be 100. And the serum creatinine doesn't look very bad. So you have to understand lack of awareness, underutilization of the albumin excretion in the urine, urinary albumin excretion rate, which is a key marker of kidney damage. And only half of the patients who have high risk for CKD are screened. The other thing we have to understand, diabetes, heart failure, and chronic kidney diseases are closely connected. CKD is common in type 2 diabetes, up to 50 to 60% globally. And if both are occurring together, diabetes and CKD, the mortality gets tripled. Heart failure is also a common complication, both in type 2 diabetes and also in CKD. Type 2 diabetes, 22% will have heart failure, which is almost 3 to 5%, 5 times the general population heart failure rate. In chronic kidney disease, up to 50% will have heart failure. So this is the data which makes us aware that the heart and renal and metabolic, the diabetes, they are very closely linked together. The progression of CKD is associated with adverse outcomes. more hospitalization as the chronic kidney disease progresses, the death from any cause, and cardiovascular events. So we have to understand that by diagnosing chronic kidney disease, there is enough data to show that not only you are trying to intervene, to treat, to prevent the progression, to retard the progression of chronic kidney disease, but also to diagnose heart disease, to intervene, to prevent in the progression of heart disease. So this is a two-pronged. So as an internist, as a physician, as a general practitioner, it is our duty and responsibility to diagnose chronic kidney disease, to diagnose diabetes, and to diagnose heart disease at the earliest. It is very easy to diagnose chronic kidney disease. You just need to do two tests. One is serum creatinine and another is albumin excretion in the urine. You must change your mindset to doing urinary albumin excretion rate. It's not very difficult to do. All labs can do it, good labs which are standardized. They can do serum creatinine also. It has to be a good lab. They can convert the serum creatinine into eGFR, just have to put it in the formula that most labs are doing. You do an albumin creatinine ratio, not very difficult to do, which will give you an early assessment of small amount of protein leak in the urine. So remember these two tests. There are other markers, I'm not going to go into detail, which can tell you about kidney damage. If the albumin creatinine ratio or urinary albumin leakage increased, or if the serum creatinine is showing eGFR has also got reduced, you repeat these tests, confirm them, and then you have the diagnosis of chronic kidney disease. Not very difficult to do. You don't need a very sophisticated instrument. You can do a field survey, you can do screening. Just collect the samples and bring it to the city and do. You can do it in periphery also, not very difficult. In a diabetic of type 2, you must do these tests at the diagnosis of diabetes. And please do it every year. I got patients of diabetes for 10 years, 15 years. Nobody has checked their urine. Nobody has checked their serum creatinine. They are getting blood sugars done. And now they have come with renal failure. We don't know at what stage the kidney disease manifested. Forget about the intervention. We don't even know. So I think this is a very important thing to understand. And I have already said eGFR and the spot urinary albumin creatinine ratio. Just have to collect the urine, spot urine, and get ACR, the albumin and creatinine. And then intervene. If you find that eGFR is reduced, this is the classification of chronic kidney disease, which you will get in all textbooks, internal medicine, diabetes, Harrison textbook also, all nephrology textbook. This is based on the eGFR, which is from the serum creatinine. It's not an estimate, it is not by DTPA, it is not by inulin clearance, it is just by serum creatinine. And you find the definition, if it is less than 60 ml of eGFR, it is CKD. And then the proteinuria, most important. Same thing, spot urine albumin creatinine ratio. If both are together, this chronic kidney disease is much more severe. If only eGFR is reduced, but the proteinuria US albumin creatinine ratio is normal, then those are less severe chronic kidney disease. So this is the hard message which we have to understand. If albuminuria in combination with reduced serum creatinine is a bad situation. Even if the GFR is 70, 60, but if the albumin excretion is high, it is a bad situation. The gentleman is going to progress, and progress fast. This is the pyramid which we know in a diabetic, starting from weight management, stop smoking, physical activity, healthy diet. The first line drugs we know, metformin is still the gold standard. Using SGLT2 inhibitors like DEPA, one of the examples. RAS inhibition, very important. And using statins. This is the first line. Then go up to GLP-1 receptor analogs, very important in type 2 diabetics. Antiplatelet drugs, non-steroidal MRAs, mineralocorticoid receptor antagonists, very important drugs. Others are glycemic control, blood pressure control, lipid management. This is the overall flow. I will not go in detail. Lifestyle management is the base. No excuse. You need to counsel and spend at least 5 to 10 minutes with your patient for all the lifestyle changes which are required to be done. First line drugs I have mentioned. Regular assessment of blood pressure and protein excretion. Not very difficult. Anybody can do, even a paramedic can do. General practitioner can do, internist can do, specialist can do. Just need a good lab and a good BP instrument, nothing else. Then the additional risk-based interventions. Tighter control of blood pressure. Blood pressure control should be 120, 80 or below. The lower the better, what the patient can tolerate. Proteinuria, our aim should be, person should go into remission. Not possible in all cases, but that is the aim. If you do one intervention, suppose you are using antihypertensive, telmisartan or RAS inhibition, then add another drug like SGLT2 inhibitors. Check the proteinuria. If it is still there, you add the next set of interventions. Keep on adding till you are able to get the maximum benefit and the maximum tolerated doses of these drugs. That is the basic premise and skeleton of management of these diseases. Not very difficult to understand and not very difficult to intervene and implement. I will not go into these details, but we should remember these are pivotal studies which have established the role of RAS inhibition, telmisartan or losartan or ACE inhibitors, the use of other interventions, the use of DEPA, the SGLT2 inhibitors, using drugs like the Renal, which are basically MRA, non-steroidal mineralocorticoid receptor antagonists. So these studies established that these drugs can be used and they are safe, they are effective, they take care of both the cardiac and the renal manifestation. That is most important. You must have heard of this study or read it in the New England Journal of Medicine, the use of GLP-1 receptor agonists. We should learn about these set of drugs. They are coming up, they are very useful, and they should be used aggressively. One of them is semaglutide, which was used in type 2 diabetics and has shown both renal and cardiac benefits. Fineron, these are the two studies, the Fidelio and Figaro, which showed that this non-steroidal mineralocorticoid receptor antagonist is effective in diabetic patients who have proteinuria, both cardiac point of view and also the progression of diabetic kidney disease, 14% reduction, and kidney outcomes 23% risk reduction. These are patients who are already on receptor blockers, ACE inhibition, already on this intervention. And some of them already are getting the SGLT2 inhibitors like DAPA. So on top of it, when these drugs are added, you find a further 14 to 23% reduction. So I think these are studies which are putting these interventions on a very strong footing. So that's why we are telling that the diabetes with chronic kidney disease due to diabetes or diabetic kidney disease and the heart vascular involvement and the heart disease because of diabetes, these are the 4 pillars for intervention. The RAS inhibition, use of SGLT2 inhibitors, the non-steroidal mineralocorticoid receptor antagonists, and GLP-1 receptor agonists. Spironolactone is also a mineralocorticoid receptor antagonist, and we have used it. It is also effective, but has a lot of side effects. The issue is these drugs have to be used almost lifelong. So the drug has to be easy to use, and the side effect should be minimum. That is what has been shown by Renal or non-steroidal mineralocorticoid receptor antagonist. This is, if you combine these drugs together, starting with RAS inhibition, the mineralocorticoid receptor antagonist, GLP-1 receptor agonist, all together the benefit gets enhanced. This is what is shown here. So you combine it. The question could be either should we do it in one go or in steps. The important message with this slide is giving you that the use of these drugs is done in very small number of patients where they should be used very liberally. In type 2 diabetics or in patients with chronic kidney disease, this is the use of ACE inhibitors, only 20%. And if you look at the SGLT2 inhibitors, it is 0.07%. It is dismal. We have to be aware. I'm not saying that every general practitioner should start using it, but you should be aware. And you should refer these patients and motivate them. Please get your diagnosis, please start the intervention. Tell the specialist, if the endocrinologist is not using, tell him why you are not using this drug. Please use it. So I think this has to be understood. The same thing is shown, very low use of GLP-1 receptor antagonists. This is understandable. These are new drugs. I have also used it in less than 10 patients. It is not marketed freely in India, difficult to get. It's an expensive drug. The one drug, GLP-1 receptor agonist, which was used was by injections, injectable semaglutide once a week. And it's a little expensive. Oral is also available. This is, I'm just showing a few patients. A patient who is on metformin, angiotensin receptor blocker, and pravastatin. And then you find that his GFR is very good. He has a totally uncontrolled diabetes initially, which got better with the use of these drugs. We would see the patient is fine. Why worry? GFR is very good. But you don't have the albuminuria excretion in the urine. So I think we should use both protein excretion, the urinary albumin-creatinine ratio to reach to a conclusion, and also look at the history that he may be having an atherosclerotic heart vascular disease. GFR may be very good, the sugars may be controlled, but he may still not be in a safe zone. So you have to assess the eGFR and also assess the urinary albumin-creatinine ratio, which will give you an idea. If the GFR is good but proteinuria is high, in this range, he is in a bad situation. So I think we have to diagnose, at the diagnosis, do in type 2 diabetics both these two tests. So it is just not the blood sugar control, it is just not the eGFR, but it is also the protein excretion in the urine, which is very important. If there is no albuminuria, the patient is safe. Continue your management, diabetic control, blood pressure control, lifestyle management. They should continue. But we know that no protein in the urine excretion, albumin is nil. The progression, the possibility of progression is very low. So I think this is a learning which is very important, and this CKD classification very clearly tells us that combined low GFR or GFR reduction, or on follow-up if GFR is going down, and albumin excretion in the urine, which is progressing, is a bad situation. These patients would need more aggressive intervention. And as I told you, that 4 pillar interventions in a patient who is not having much of albuminuria, whose GFR is not very low, you may go in steps. But if you get a patient who suddenly has low GFR, heavy proteinuria, you have no time. Do all the interventions at the earliest. The other thing is refer these patients to nephrologists and cardiologists. It is not that you are passing the baton. We used to play a game, let us pass the buck in the schools. It is not passing the buck. You are referring the patient, you are intervening, you are also consulting, and the baton is not being passed. It's a close cooperation which is required. When you refer the patient, the physician, the specialist may refer it back to you for further management. So that has to be understood. So it's a multidisciplinary collaboration and approach which is very important in patients with CKD and diabetes. And as I mentioned, new therapies, these 4 interventions which I told you have come up in a big way. They have to be used. They have come in all the guidelines, the hypertension guidelines, the diabetic guidelines, the cardiovascular, and the kidney guidelines. They have become, because the studies which have shown their efficacy have been randomized studies, large studies, and significant benefit. So there is nothing to say that why are you using these drugs. Only thing is, patient may question you, why have you not used these drugs? So please use them, and use them judiciously. That is very important. And as I said, the interventions have to be based on the stage of proteinuria and reduction in GFR, what you see. If it is in a later stage, more advanced chronic kidney disease, more aggressive diabetic-related kidney disease, very quickly add ACE inhibition, receptor blockers, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonist, and GLP-1 receptor agonists. You may take few weeks or months each, but please do it. In 4 or 5 months, all these interventions should be in place. I would do it even quicker because we have no time. These have already been talked about. If the GFR is low, some of these drugs are advised not to be started. So you can consult the specialist about it. Like the SGLT2 inhibitors or DAPA, the GFR, low GFR is rated as 25. If you're using AMPA, Even you can start with the GFR is 20. These drugs can be started at this GFR, but even if the patient progresses and reaches dialysis, you can continue to use. About Renal, things are still evolving. There is a cutoff GFR below which you don't start, and there is a cutoff GFR below which you stop. But the trials are going on. The situation may become similar as SGLT2 inhibitors. The other important thing is the residual risk is indicated by the progression in the eGFR and also by the residual albuminuria. If there is residual albuminuria, then you put the other intervention which you have not used. If the albuminuria has disappeared, if eGFR has stabilized, patient is in remission. You may not introduce the next intervention if clinically you feel so. Follow these patients frequently, at least every 2 or 3 months. This is important. Just to see the control of blood sugar, control of hypertension, the change in eGFR, and the residual proteinuria. So I think this is the study which I mentioned, the FLOW study, which has established semaglutide, which is a GLP-1 receptor agonist, is a very useful drug. It is going to be very effective even in patients who are already on SGLT2 inhibitors, Renal, or telmisartan or ACE inhibition. This could be the other 4th pillar to take care of the progression of the kidney disease. Last few slides I'm going to mention about the heart failure. Heart failure, we only feel when the ejection fraction is reduced that this is heart failure. No. You may have patients where the ejection fraction is normal, 60%. But if you get an anti-proBNP, which is a biomarker of heart failure, if it is raised, this is the term which we know, the heart failure with preserved ejection fraction. These are very difficult patients to manage. Their outcomes are also very bleak. It is very commonly seen in patients with chronic kidney disease. So these interventions which I mentioned have been shown, including Renal, to improve the heart failure with preserved ejection fraction. So this is very useful even for the cardiologist. So I think these drugs which I have mentioned, they will go a long way, not only tackling the progression of chronic diabetic kidney disease, but also the involvement of the heart, especially the heart failure. And lastly, drugs like semaglutide, they also are very useful for weight reduction. So weight control and controlling obesity is also very crucial. So this intervention using the semaglutide, which has been shown in the FLOW study that it not only tackled the cardiovascular events and the death from any cause and the chronic kidney disease because of diabetes, but it also resulted in weight loss and corrected obesity. So I think the other message is that GLP-1 receptor agonists can be used even in patients who have reduced eGFR. You can use it even in that situation. It is reasonably acceptable and is useful and effective. So I think because the alarm is already ringing, I'm going to finish and give the message that we now have emerging therapeutic options for these patients, tackling the cardio-renal metabolic axis. It is very important to use them, all the 4 pillars, but the treatment has to be patient-centric. A multidisciplinary approach is most important, and seeing the burden of chronic kidney disease and diabetes, the other important thing is obesity, which is a fulcrum, which is a focal point of generating all these metabolic disturbances, triggering and also progressing and maintaining the metabolic derangement. So by GLP-1 receptor agonist, obesity is very effectively cut down and normalized to a great extent. So remember, by RAS inhibition, by the SGLT2 inhibitors, GLP-1 receptor agonists, the non-steroidal mineralocorticoid receptor antagonists, we have these 4 pillars taking care of the metabolic abnormalities, the hemodynamic, and the inflammation and fibrosis. These are the other therapies which are being studied. The endothelin receptor, acting at endothelin receptor, and aldosterone synthetase inhibitors. They will come up very soon, but at present, this is what we have in our armamentarium. So we should not be disheartened because we have enough interventions available, at least 4 sets of interventions, which have been shown in large randomized studies to be effective, both for the chronic kidney disease, for the heart disease, for metabolic control. Lastly, I'll give you this information and message that by using these interventions, an average patient who is likely to go for dialysis and transplant, you will be able to give 5 to 6 years of life, which is dialysis free. The idea is we intervene so that the need for dialysis doesn't occur. And the reduction in EGFR is just 1 ml per year, which is an age-related reduction. So as long as the person survives, he may not need dialysis or transplant. That is still far away, but that is the goal. Thank you very much.
Thank you, sir, for a great oration. And also thank you personally for being part of my journey at SGPGI when I joined in 1990, and you were part of it. A great oration, and you mentioned in passing that it would be cardio, renal, hepatic syndrome. That is not far off. It actually is included in the terminology nowadays, and a lot of pressure is there, including liver disease, because 10 to 15% of all diabetics have chronic liver disease. So that is also coming up. A great oration. And if there are no questions in this oration, so thank you for a great oration.
Thank you, sir, for the wonderful oration. Very rightly pointed out. I think just 2 points. Manage sugar, manage blood pressure, and you have done half of the work. So thank you, sir.
To the chairpersons, Dr. A.P. Singh sir, Professor Arvind Gupta, and Dr. Rohit Gupta sir.